Good morning, good afternoon, good evening, dear colleagues, depending on from where part of the world you are watching us. Thank you for attending this webinar today that is organized by the study group on ICU infection and sepsis of ISAC, jointly with the ESCMID study group on infection of critically ill patients and KIMS critical care. I would like to thank all the groups and especially ISAC and the executive manager, Fee John Stones, for all the support for this organization. I would like to introduce you my co-chair, Professor Hakan Erdem, that is an infectious diseases and clinical microbiology specialist and lead coordinator of IDIRI, a major global clinical research platform. He's a professor at Gülhane School of Medicine, Ankara, Turkey, with extensive experience in ICU and community-acquired infection, clinical teaching, and international research. He's the current education officer of the ESCMID study group of infection in critically ill patients that co-organizes this ISAC event. Professor Erdem has received the ESCMID Fellow and IDRA Fellow titles for distinguished contribution in the field of infectious diseases. Welcome, Hakan, and happy to co-chair with you.
Thank you very much, Despoina. It is a very nice introduction for me. And I would like to introduce Professor Despoina Koulenti. She's an intensive care specialist and consultant in critical care at King's College Hospital, London. Also, she is a visiting professor at the Universities of Thessaly and of Ionia, Greece, and an honorary research fellow at the UK Centre of Clinical Research, the University of Queensland. She is a member of the executive committees of the ISAC study group on ICU infections and Sepsis of ISAC and the ESCMID study group of infections in critically ill patients, and immediate past chair of the Academy of the European Society of Intensive Care Medicine. Despoina's research mainly focuses on severe hospital-acquired infections, especially in the ICU setting, and on severe pneumonia, and she has important contribution to research, education, and expert committee globally. Thank you for co-chairing the session with me, Despoina.
And I have the pleasure to introduce our first speaker, Professor Jason Roberts. I think you all know Professor Roberts. Professor Roberts is director of the University of Queensland Centre for Clinical Research and also an NHMRC Leadership Fellow. He's also consultant clinical pharmacist at Royal Brisbane and Women's Hospital of Brisbane and interim director of the Hurston Infectious Diseases Institute. Professor Roberts has authored over 650 publications and has secured more than 55 million in research funding and supervised over 20 PhD students. He's a world-leading clinician scientist with research focus on optimizing antimicrobial dosing in critically ill patients. Very impressive. And Professor Roberts is recognized as Australia's top researcher in critical care and communicable diseases. He contributes to international guidelines and advances global management of infectious diseases. It's an honor to have Professor Roberts with us today. Welcome, Jason.
Now I'm just going to share my screen and make every assumption that has come through properly and begin my presentation on practicing precisely and focusing on optimization of antibiotics. Of course, the focus of this specific seminar is focusing on critically ill patients and patients with very challenging infections, and so that's really the focus of where this presentation comes from. These are just some disclosures that I thought I'd add. And I've got a couple of learning objectives here to talk about the importance of pharmacokinetics and pharmacodynamics for defining the paradigm for antimicrobial dosing and therapeutic choice more broadly, to understand how to apply PKP principles to optimize drug dosing, and of course how to consider this in the context of tissue penetration for antimicrobials as well, because for some parts of critically ill patient therapy for severe infections, particularly pneumonia and CNS infections. This is a really important consideration, which we only consider partly in some of our choices. But anyway, let's get straight into it. So the prescribing process, of course, as we know, the most important part of this is diagnosis and making sure that when we are making a decision about treatment for a patient, that we have an accurate understanding of what we're treating. And so that diagnostic process is something that's very important. In the context of infections, once we've made that diagnosis that the patient does have an infection, or we think that there's a high enough probability that we do, that's when, from a prescription perspective, we make decisions around the choice of antimicrobial, the dose, how we monitor that antimicrobial, and for what duration that we will do so. Now, of course, some of these practices are inherently precise, whereas others are an evidence-based guideline that are applied to all. So from a prescribing process, the first comment that I'd like to make is that there's a lot of things that we do for the individual patient which are actually geared towards that specific patient. It's not just a flat guideline approach. We are trying to make decisions about which drug is appropriate for that patient, given what we think their infection is, and in the context of what we think their organ function is and the characteristics of the patient. And so a lot of the decisions we do make are inherently about trying to be precise with our choice for the patient. How often we are often doing this in the context of a guideline framework. Now, I want to make the point that guidelines don't set the maximum standard for, or the maximum approach which you should be applying for dosing. They set the minimum standard from which you then make decisions to further optimize treatment. Guidelines are often based on studies, of course, which have an inflexible intervention. So it's an intervention which can be applied to all the participants in the study. And so therefore that guideline can typically only make a recommendation about those interventions that are incorporated into those trials. So they of themselves are not precise, but they set the baseline through which treatment for the individual should be provided. So from a dosing perspective, where do doses come from? So why is it that when we see a product information which for a particular antimicrobial, that we can't necessarily accept that that dosing regimen is something which is appropriate for all the patients that we may be confronted with? Well, if we think about the process through which antimicrobial doses are developed, essentially the exposure of an antimicrobial which effectively kills bacteria is defined in an in vitro setting. And then once that exposure has been defined, then it is tested for safety and efficacy in either healthy volunteers or alternatively a relatively healthy group of patients, so patients that aren't seriously unwell. At this stage here, dosing regimen development occurs, and that dosing regimen is then taken forward into clinical trials and is tested in a relatively homogeneous group of patients. They're patients that may have pneumonia. They may be patients that have complicated urinary tract infections or intra-abdominal infections, skin and soft tissue infections, but they're relatively homogeneous. They don't cover the breadth of patients that we end up treating in clinical care. So the kind of patients who aren't included in those studies are the patients in whom there has not yet been validation of that dosing regimen as being appropriate. And indeed, there are many reasons for us to think that because drug behavior, so the pharmacokinetics of a drug, is different to that which is seen in these registration trials, that indeed those dosing regimens may not be optimal for these other patient groups. So we often think about this in the context of critical care, which is indeed the topic of tonight's presentation. But of course, we see it in other parts of the hospital as well. Patients with renal failure, liver failure, that problem of obesity, patients with severe burn injuries, those who have received transplants, cystic fibrosis patients, those that are receiving extracorporeal therapies, ECMO, renal replacement therapy, plasma exchange. So in that context, I think it's quite clear that using the same dose across all of those patients may not be optimal for each of them. It may not be precise for the individual requirements that that patient has. And of course, the other big challenge about antimicrobials is they're not like a hypertensive or a sedative drug where we're titrating to a measurable endpoint, such as for a vasopressor, we're titrating to a mean arterial pressure, or a sedative, some measure of sedation. We don't have that ability to see how well a bacteria is being killed by that antibiotic. And therefore, we can't rely on clinical markers, because to see a resolution in those markers can take many hours, if not days. And if we're waiting that long to find out that this isn't the optimal treatment, then of course that patient risks having a dramatic failure. Therefore, we aim for PK/PD targets. They very much inform what our choices are for dosing. So what is PK/PD? Many of you will have a good understanding of this, but not all of you will. So PK/PD essentially links dose with an endpoint. So dose is pharmacokinetics, endpoint is pharmacodynamics. Pharmacokinetics at its most basic sense is the relationship between the dose of drug that's administered and the concentrations that are measured in the body. Whereas pharmacodynamics is the relationship between concentration and pharmacological effect. So PK/PD, of course, is then that relationship between dose and pharmacological effect, which is the endpoint. Now, we know at an in vitro level that antibiotics have a very strong exposure effect relationship. We can see how changes in the exposure of drug in those in vitro models can have a dramatic effect on the rate and extent of bacterial killing, even emergence of resistance. And so we know that concentration matters, which means that dose matters. And of course, dosing that does not align with optimal PK/PD will result in suboptimal effects. This can lead to clinical failure. It can even lead to drug toxicity when concentrations are very high. And of course, emergence of antimicrobial resistance is considered to be likely with low drug exposure, and patient mortality is also associated with suboptimal dosing. So from a critical care perspective, we tend to think about the patient and their pathophysiological manifestations and how they affect pharmacokinetics. This is really a very basic paradigm for how you could be considering the need for altered dosing in an individual patient. We'll have some patients that don't have end organ dysfunction but become very hyperdynamic as a response to the infection insult or maybe some other insult that they've received, such as trauma, surgery. And so this can mean that the patient becomes very hyperdynamic in response to that insult that they've received. And that can cause them to have an increased cardiac output because of all the inflammatory cytokines which are circulating. That increased cardiac output, of course, increases the perfusion of eliminating organs, such as in particular the kidneys, but also the liver as well. But given that many antimicrobials are renally cleared, increased perfusion of the kidneys means that you have increased rate of delivery of drug to the kidneys per unit time, and therefore increased drug clearance. We can have some patients in whom we struggle to maintain their blood pressure, so we give them extra resuscitative fluids. And of course, if we're giving a lot of extra water to a patient who's receiving a drug which is water soluble, that's going to have a dilutional effect. And in its very basic sense, that's a way to describe what changes in volume of distribution can result from. Of course, we have patients that have end organ dysfunction, and we are a little bit more familiar with how to dose adjust those, even if sometimes the descriptors for what level of acute kidney injury a patient may have. And then there are patients that have organ support requirements, as I referred to before, and the effect of those on dosing requirements is a little bit less certain. Important to all of this is that any dose adjustment must have some insight to what the level of susceptibility of the known or likely pathogen is. So if we think that the pathogen that's caused the infection has a very low MIC, it's unlikely that any of these changes in critical illness are going to affect the success of killing that bacteria because it is just so susceptible. It's when the MICs are getting close to the MIC breakpoint that it becomes particularly problematic. So let's have a look at the effect of some of these changes in organ function and what this can mean for drug exposure. So this slide here just essentially is trying to highlight the importance of renal function. This is a data set of patients receiving one of various beta-lactam antimicrobials, whereby those antimicrobials were measured as part of a therapeutic drug monitoring program. On the x-axis here, we can see creatinine clearance, which is a measured creatinine clearance. And on the y-axis is a trough concentration to MIC ratio. So trying to account for antimicrobial susceptibility as well as drug exposure. As you would expect, as creatinine clearance increases, you see a decrease in the trough concentration to MIC ratio. What is really important to note here is how high some of these creatinine clearance values are. You can see that in the midpoint here, where the line of best fit crosses the trough concentration to MIC ratio of 1, that's at a creatinine clearance of 150 ml per minute. Now, for many of us, that's a pretty high renal function for you or I as we sit where we are around the world. But many of these patients in the ICU have this far greater renal function as part of this response to the infection insult that they have. We've termed this augmented renal clearance, which means that their renal clearance, the removal of the drug, is augmented above what we would see in patients that don't have this same pathology. And so this can result in very low drug concentrations unless dosing tries to account for that. Very briefly, from a volume of distribution perspective, this can dramatically change in critically ill patients. There's some data here for vancomycin on volume of distribution on day 2 versus day 6 to 8. So day 2 is the second to left column, day 6 to 8 is the right-hand column. And for vancomycin, the volume of distribution essentially halves as the patient starts to improve. So initially it has a much higher volume of distribution with all the resuscitative fluids they're receiving. And then as the time of they start to get better, the volume of distribution reduces, so that we can see that there's a change in behavior of the drug throughout the course of infection and as the patient resolves. For another drug like ciprofloxacin, which is a moderately lipophilic drug, so it's more lipophilic than vancomycin, which means it penetrates more extensively through the body. It has a higher volume of distribution to start off with. That means that with all the resuscitative fluids that the patient receives, because it has a larger volume of distribution to start off with, that extra volume of fluids has less of an effect. And indeed, we don't see significant changes in volume of distribution for ciprofloxacin like we do for other hydrophilic drugs like vancomycin. So if we would try to quantify this from a pharmacokinetic parameter perspective, so here on this slide here, we just have some data comparing change in drug clearance and drug volume of distribution for a number of different antimicrobials in ICU patients versus healthy volunteers. And essentially what we see here is in these very select patient groups, we can see dramatic increases in drug clearance. We can see dramatic increases in volume of distribution. So in some subpopulations of critical illness, we will see quite changes in pharmacokinetic parameters. What we'll come on to soon is how that manifests in terms of drug concentrations. From a susceptibility pattern perspective, that other challenge about critical illness, but also other patients that are in the hospital for a long period of time, is they're more likely to have more than one infection and therefore more than one course of antimicrobials. And this means that we tend to get that selection pressure that occurs, which means that we're more likely to see less susceptible bacteria causing subsequent infections. A very simple study here, a German surveillance study of carbapenem MICs in the ICU versus patients in the ward, essentially showed that for carbapenems that the MIC is 2 to 3 dilutions higher in the ICU versus the wards. So this is important because it means not only we're likely to see altered pharmacokinetics, but that pharmacodynamic denominator, so in PK/PD, that MIC value is also likely to be higher. So that, of course, introduces some additional challenges from a dosing perspective. Now, there's a very important position statement that was published in Intensive Care Medicine in 2020. And this table essentially summarizes the antibacterial PK/PD literature at that time, essentially defining the PK/PD targets for efficacy based on preclinical data, but also the clinical pharmacodynamic data as well, as you can see in the column second from the right. And in the far right column, the clinical PK/PD threshold for toxicity. This is done for each of the different antimicrobials. Now, the reason that these values exist for a PK/PD target for efficacy or a PK/PD target for toxicity is because there have been observational studies which have been performed looking at the effect of drug exposure on patient outcome and have been able to show that these exposures in particular are associated with better patient outcomes from an efficacy perspective, and the other exposures are associated with toxicity. In between both of these two columns on the right-hand side of the page, this is effectively defining what the therapeutic range for these drugs are in critically ill patients. And so when we look at some of the clinical outcome data that exists for almost all the different classes of antimicrobials, it becomes quite clear that it doesn't matter what kind of bacteria or or antimicrobial that we're considering, there is an exposure effect relationship, which, as you can see from here, it might be associated with improved microbiological or clinical cure, or even survival as well. And so this is very instructive to us about the importance of dosing, and that we should be trying to achieve these PK/PD targets as part of therapy. So this is the position paper that I alluded to, and unfortunately, the first author, the great Hafiz Abdulaziz, can't be joining us tonight, but we're very grateful for his contribution to this paper. And you'll note that ISAC indeed was one of the contributing societies to this position paper, which was co-signed by 4 different international societies. This paper also has data on antifungal PK/PD as well as antiviral PK/PD. Okay, so one of our big challenges, of course, in critically ill patients is that there is altered pharmacokinetics, but the extent of altered pharmacokinetics is very difficult to predict. And so that's why PK/PD variability is a challenge. So the DALI study was a really important study. This was a data collection done in 2010, then later published in 2014. It studied 68 intensive care units throughout Europe. 450 patients contributed overall to the study. This is the beta-lactam data for 360 patients. 8 different beta-lactams included. On the y-axis here, we have a log2 scale of the concentration to MIC ratio halfway through the dosing interval. Essentially, you can see that for each of the different antibiotics, there's quite a significant exposure variation, up to 1,000-fold variation in concentrations, PK/PD ratios. Now, given that we're typically using a dose of antibiotic, which we think will achieve a target, this is quite concerning to us because it means that we don't always achieve that. Indeed, many of our exposures are overdose and many of them are underdosed. In this particular study, about 16% of patients had a concentration below what we would consider to be the minimum exposure we should be aiming for. And those patients were 3 times more likely to fail treatment. So even in this very general cohort of critically ill patients, did we see an exposure effect relationship. Concerningly for vancomycin, a drug which we have therapeutic drug monitoring available for, this is the data from the DALI study for vancomycin. On the y-axis is the trough concentration, and on the x-axis is the vancomycin dose. Now, we would expect to see a little bit of variability there because renal function hasn't been layered into this graphic. But the key point I wanted you to take away from here is the number of patients that have very high, so toxic concentrations above, say, 25 milligram per liter, if we could use that as a reasonable threshold, and the number of patients that have low drug exposures. If we've got it marked there as a trough concentration of 15, but even if you apply it as low as 10, there's still quite a large proportion of patients that are underdosed. The main point that I want you to take away from this is that it's one thing having therapeutic drug monitoring available, it's another thing using it properly, and that's certainly not something which is consistently done for that drug. What about beta-lactams and vancomycin in renal replacement therapy? So I've highlighted the importance of and the challenge of dosing in extracorporeal circuits. Well, the SMART study was a study in 450 critically ill patients, maybe 29 ICUs in 13 countries, and essentially was able to demonstrate huge variability in drug concentrations, as you can see here for meropenem top left, piperacillin top right, tazobactam bottom left, and vancomycin bottom right. Statistical relationships between drug exposure and patient outcome was demonstrated in this study too, even for patients receiving renal replacement therapy, showing that dosing is important. What about ECMO? Well, we didn't look at concentration response relationships in this study, but we did note that there's huge variability in exposure for each of these different 11 antimicrobials in this ASAP ECMO project, which was led by Kiran Shekhar, an intensive care physician from Brisbane, Australia. But that 40% of patients had dosing that was suboptimal. And if I could get you to focus in particularly on piperacillin and vancomycin, which are on the right-hand side of the screen, there's quite a significant number of patients there that have been underdosed with those drugs, which are commonly used drugs, and that means that we commonly get dosing wrong in patients receiving ECMO. But there is, of course, hope for how to improve upon this. And that comes from population pharmacokinetic studies. So that's essentially where a mathematical algorithm is developed to define why concentrations change the way they do and what are the covariates which can help predict the need for altered dosing and what dosing interventions we can be applying. And so this is some data from Fredrik Cheval from Sweden, 50 patients with septic shock, meropenem population pharmacokinetic study, essentially showing that as you move from short infusions to longer infusions, you dramatically increase the likelihood of having an effective exposures regardless of how high the patient's renal function is. So this is quite reassuring because it's starting to tell us about how we can get better with dosing. From a renal replacement therapy perspective, this is a paper that was very recently published in Intensive Care Medicine, which is an extension of the previous SMART study that I presented. Essentially, it is again another population pharmacokinetic analysis developing a dosing nomogram, which is able to define what doses of meropenem and piperacillin tazobactam are needed for the different durations of renal replacement therapy, all the way from SLED through to short SLED, so slow, low efficiency dialysis, through to continuous renal replacement therapy at different renal replacement therapy settings and different levels of urine output. So this, to me, is like fantastic. This is externally validated in a different data set and certainly performed very well. So it's very reassuring about how we can be better dosing in renal replacement therapy. Similarly, for ECMO, we have this data that's also emerging from the ASAP ECMO study. Again, these are population pharmacokinetic studies which recommend what dose should be used in those specific patient populations and provide us with a lot of reassurance. One point I'll just briefly touch on is that this data isn't even really considering the site of infection. So on the right-hand side of the slide here, we can see some data that we have from a study called the NewDose study. So it's dosing antimicrobials in pneumonia. This is specifically ventilator-associated pneumonia, with the black dots representing plasma concentrations, the red squares representing ELF concentrations, and you can see that generally the concentrations in ELF are substantially lower. This is a log 10 scale, and this means that if we are wanting to ensure effective concentrations at the site of infection, here in the context of pneumonia, different dosing to what we are trying to deliver in plasma is required. So what are our options for better dosing? Any of these options can be applied depending on what your resources are that you have available to you. Dosing nomograms, as I've highlighted for that SMART renal replacement therapy study, are a great example. Here are some vancomycin dosing nomograms where the pharmacokinetics that has been defined for the patient population, so here critically ill patients, can then be used to define what dosing regimens should be used prospectively in patients. And studies that have been done to validate these nomograms show far better target attainment, so achievement of effective exposures, than you would see with just standard dosing. So dosing nomograms do work. From a therapeutic drug monitoring perspective, I might just talk very briefly about this. Essentially, randomized controlled trials for this have not been done very well, and I don't mean that disrespectfully, because trying to perform a multi-center randomized controlled trial to deliver a therapeutic drug monitoring intervention is very, very hard, and anyone that says that it isn't very hard has never tried to do one. But essentially, most of the studies that have been done are underpowered. So the target study is probably the best of the therapeutic drug monitoring studies that have been done. Effectively, they were able to demonstrate they could improve the achievement of effective concentrations with a numerical but not statistically significant improvement in patient survival. But really, it's probably underpowered by 4 to 10-fold. And that just, if anything, highlights what the likely effect size is of a therapeutic drug monitoring intervention for the inclusion criteria that they used for that study. So in conclusion, I think that we inherently try to practice prescribe precisely, but we don't necessarily do that from a dosing perspective. And that's sort of highlighted in some of those studies like the DALI study and the SMART study. But there are tools that are available for us now that allow us to be a bit better. And I certainly think that we are starting to see some more of those larger trials that are really highlighting the effect that these dosing interventions can have on improving patient outcomes. And so I'll conclude there and be happy to take any questions now or at the end of the in the question and answer time.
Thank you, Jason. You hear me?
Yes.
Thank you, Hakan.
Yeah. Thank you, Jason, for your great presentation. And I was very happy to listen to your talk, which I was expecting for a long time. We have a couple of questions. The first one is, what about diabetic foot infections with peripheric arterial disease? And what about the concentration in antimicrobial and its effectiveness?
All right, well, these are the kind of super specific questions which really highlight why PK/PD is important. Trying to do a trial of what is the optimal dose for a diabetic foot infection, peripheral patients that have a peripheral vascular disease is something which is highly challenging. Essentially, it's all about trying to deliver the effective concentration at the site of infection, noting that we don't want to cause systemic toxicity. Typically, in this instance here, having awareness of the likely pathogens is quite important. Commonly in diabetic foot infections, this can be Pseudomonas. So this means that we're, of course, aiming at a slightly higher MIC. So we tend to, in this case here, we tend to aim for concentrations that are somewhere between 3 to 4 times MIC to try to ensure that we achieve effective concentrations at the site of infection. Now, aim that we have for doing this is to focus on that very early on in therapy and not be focusing on giving very, very high doses thereafter, because these patients often have some sort of chronic renal disease as well, and we don't want to be causing drug toxicity. So I hope that gives a bit of a context for how we try to be flexible in ensuring effective concentrations initially without causing drug toxicity later down the line.
And there is another question here. The question comes in a general understanding. It says, what about a patient who is ingrowth or any past swab from urine sample collection, which is resistant to all antibiotics, I think. It comes as which is resistant to all organisms, but I think it is which is resistant to all antibiotics. Do you have any specific recommendations to it? It's
like one of those impossible situations. What dose do you use of an antibiotic which doesn't work? Look, in truth, clinical medicine, you're always choosing the best option you have. And now once you've made the selection about what is the best drug you have, then you try to give the best dose you can. Now, when we're talking about infection in the urinary tract, there is often, for many drugs that are renally clear, there's a concentrating effect that occurs there. And so we do have a slight advantage there for if it's a growth somewhere else in the body. But that being said, when it's resistant to all antibiotics, it does make it very difficult to choose the antibiotic. But once you have chosen what antibiotic you hope will work, assuming that there's no other interventions that can be applied, then you just have to use the best dose you can.
What about inhaler or inhalational antibiotic administrations?
So inhaled antibiotics are something which is a little bit controversial. My personal belief is that it must be something that can work in the right patient group, which that patient group that is, and whether or not that's more so from a prevention or an early intervention perspective, as opposed to really being able to test it in someone that has a very serious pneumonia, is something which is a little bit unknown. I think that when you're comparing it against best available therapy, we tend to have some pretty good approaches for delivering best available therapy. And so really trying to isolate in a clinical trial scenario what is the right inclusion criteria that should be being applied is something which is a little bit challenging. So overall, many of you will know that the evidence is not strong for use of aerosolized antibiotics, but I'm pretty confident in years to come that we'll get the intervention right and the patient selection right for that. And I do believe that it is a useful intervention.
I would like to... sorry.
Sure. I was going to ask that question. Should we continue or should we skip to the other,
we have the opportunity to have a worldwide expert with us. So I will take the opportunity to continue because we have time, because unfortunately Dr. Abdulaziz is not here. So I would like to thank Jason and ask some of these questions. There's a question about how much do you reckon an estimated clearance based on CKD or the Cockford equation is able to predict augmented renal clearance. Is it a good surrogate, or what do you suggest?
So personally, I'm relatively comfortable with Cockcroft-Gault, and I know that a lot of people say, "Oh, how could you do that? That's an equation derived from medical patients in 1976 or whatever it was." But actually, in population pharmacokinetic studies, it actually usually performs pretty well. There are some studies, but there's less of them, whereby EGFR performs better. But I typically tend to be quite comfortable with Cockcroft-Gault. One of the reasons I think it performs pretty well is because essentially, if you have a high creatinine clearance with Cockcroft-Gault, then that means you've got a low age, which is the biggest factor really for developing augmented renal clearance in a critically ill patient. And you don't have renal impairment because your serum creatinine is not high either. So it tends to perform pretty well, I think. A measured creatinine clearance is a lot more reassuring, but that being said, any data that you have, and of course, always noting what the safety window is for an antibiotic. You know, for beta-lactams, they're not like vancomycin and gentamicin, whereby we're really worried about immediate toxicity. You know, they tend to have a pretty broad window, and even if we are aiming for a higher dose initially to try to ensure that we get some early effective bacterial killing, you know, we can always back off on the dose such that we don't cause toxicity later on, just like my previous response alluded to. And we have one of the world experts in this area, Claire Roger. I think she's going to give her opinion.
And there's one more question here. There's many questions.
Claire has a question. He has a hand up. So Claire.
Okay, great.
Good morning or good afternoon, everyone. I just wanted to comment and maybe ask Jason if we should differentiate between the best way to assess renal function to adjust drug dosing and predict adequate dosing, and the assessment of augmented renal clearance itself. And using the Cockcroft-Gault equation sometime may under-recognize the phenomenon. So I would suggest to do both. One, to adjust, maybe it's a bit more complex, definitely. But if we only rely on the measure and the Cockcroft equations, sometimes we miss the phenomenon of augmented renal clearance.
I think that's a really well-made point that you know, we do the best with what we've got, and the more data we've got, the more accurate we're going to be. So, yeah, I agree with that comment that whatever data that we can have, the better the choices are that we can make.
Thank you.
We have heaps of questions for Jason. I will keep the question about beta-lactam TDM for Claire, in order to move on. Hakan, can I ask one more question? I think
sure.
it's
There is something I would like to,
question about. They asked Jason about. Wait a minute, because there are so many questions. Thank you for sending questions about vancomycin. They say, for TDM on vancomycin, do you prefer monitoring only Cmin or Cmin and Cmax, and calculate area under the curve 0-24 hours?
I'm a bit of an outlier with this one. I mean, all of the guidelines recommend performing AUC-based monitoring, and the best prospective studies tend to demonstrate that we see reduced nephrotoxicity with that approach. So I would say that that's the approach which I would be recommending that people use. In terms of my own personal clinical experience, I tend to make a judgment about how important it is to go to AUC monitoring, and I'm relatively comfortable with trough level monitoring. But that being said, we don't use a lot of long courses of vancomycin. You know, a lot of our usage, which isn't that much, is still quite empiric, and so short courses. And so I probably don't have as much experience as many of the people do with contemporary use of AUC monitoring. But I would recommend that if you can do AUC monitoring, that you should.
Thank you,
Great.
Jason.
Hakan,
Can I
you
ask
have
one more
question?
question? Yes, definitely. There is a question coming from the audience. They are asking about the management of optimization of antibiotic concentration for biofilm-related infections.
It's the same response that I'd give to the peripheral vascular disease question as well, that essentially if a biofilm is present and it can't be removed and that you're reliant only on the antimicrobial dose, then you use the best dose that you can in the right combination that will hopefully have a biofilm active agent.
Okay, thank you.
Thank you very much. And I think it's time to move on to Professor Jose. Hakan, will you introduce Professor Jose?
Sure, definitely. First, I would like to introduce the Professor Claire Roger. She is a medical doctor and has PhD and leads 3 intensive care units at Nimes University Hospital and teaches at the University of Montpellier. She has extensive expertise and is globally renowned for her work on antimicrobial pharmacokinetics, dose optimization in critical ill patients, and therapeutic drug monitoring. Professor Roger is a member of the Executive Scientific Committee of the French Anesthesiology and Intensive Care Society and has co-authored the French Beta-Lactam optimization guidelines. She is an active member of ESGCIP and also is the current co-director of the sepsis pathway in the European Society of Intensive Care Medicine. Please, Professor Roger, it's your turn now.
Thank you for the opportunity to talk about the beta-lactams toxicity and to see whether or not it's still an under-recognized matter. So here are my conflicts of interest. So probably for the last decade, we mainly focus on the risk of underexposure. In this previously published work from Jason Roberts, we can see here, looking at the PK/PD ratio of different beta-lactams, that of course, some antibiotics were not appropriately dosed in the critically ill patient. But we can also see in this population that there is a huge inter-individual variability with sometimes quite high concentration, and overexposure has become an issue in the last decades. We know that antibiotics toxicity, and especially for beta-lactams, has been underestimated, and we have collateral damage. Obviously, some of them are hematotoxicity, hepatotoxicity, but we'll mainly today focused on the risk of neurotoxicity while using beta-lactams and see the consequences for our patient. If we look into the recent literature, we can see that increasing literature has been published on this matter and provides some answers to these issues. One of the first study reporting increased neurotoxicity while using beta-lactam is this study published in almost 400 patients, mostly critically ill patients or patients with severe infection, looking at 3 different beta-lactams. And we can see in this study that the prevalence of neurotoxicity was around 10 or 50%, depending on the beta-lactam. And we can see from the TDM data that patients that developed neurotoxicity exhibited higher concentration, significantly higher concentration. Why we can fear the risk of beta-lactam neurotoxicity in our patient? There's different pathophysiological alterations, and the main mechanisms of toxicity relies on the inhibition of the GABA pathway and the inhibition of GABA synthesis. And we can see from this graph that the different beta-lactams can act at different receptors in the neurological barrier, while increasing the inhibition of benzodiazepine receptor activity, for example, for some of them, or increases the neural excitability. all these mechanisms lead to this increased neuronal excitability and lower the seizure thresholds. But all beta-lactams are not equivalent. And if we can try to classify and prioritize the beta-lactams, we should be very cautious. The first one is cefazolin, that have the higher relative proconvulsive activity based on mainly in vivo data from animal models. The second one is cefepime, followed by penicillin G and imipenem. So it's probably the beta-lactam we should focus on, but remember that all beta-lactams can still be associated with neurotoxicity. And the complexity is that among the same class of beta-lactam, the risk can be different. And this is a meta-analysis looking into the risk of seizure among critically ill patients receiving carbapenems. And you can see here that the increased risk was mainly reported with imipenem compared to other carbapenem like meropenem. And that is something that need to be taken into account while choosing the best option for your patient based on the risk of seizures. The second drug that we need to be aware of is cefepime, and there's an increasing literature in the last 10 years about the risk of cefepime-induced neurotoxicity in the intensive care unit. The main risk factors of neurotoxicity reported are related to renal function. Mainly chronic kidney disease is a risk factor, but most importantly, the appropriate dose reduction based on the assessment of renal function. And we have already discussed about the complexity of adequately assess renal function in our patient, whether we talk about augmented renal clearance or renal dysfunction. Again, but this is data published 10 years ago, the prevalence was around 50%, but probably underestimated because we don't have standardized approach to try to diagnose this complication. Another study reported again the risk of neurotoxicity while using cefepime. This cohort study showing here in patients with severe renal dysfunction, a prevalence that is much higher, was around 50% in this cohort, 50% of neurotoxicity in patients with severe renal dysfunction, as here as an EGFR below 30 milliliter per minute. And with an increased hospital mortality, but again, it's only an association, and causality is much more difficult to prove. But definitely the main determinant of toxicity is the renal function of our patient. And this is another way to illustrate this point. It's a cohort of TDM data published by the team of Jan de Waal 2 years ago. And interestingly, they reported the measured concentration of meropenem and piperacillin tazobactam based on the different spectrum of kidney function. And you can see from this graph on the left panel, the prevalence of concentrations above the toxicity threshold in two groups, patient with acute kidney injury, KDIGO 3 acute kidney injury, and patient on renal replacement therapy. And when you look into the concentration here, you can see very high piperacillin tazobactam concentration in this patient. So probably the main focus should be on this population where the risk is much higher. What are the consequences when we look into the dosing optimization? In this study, the authors look into a patient exhibiting neurotoxicity induced by piperacillin. And they found that it's not only the daily dose that matters in this population, but rather the median dose normalized to the EGFR. And you can see that the median dose was around 12 grams in both groups, those exhibiting neurotoxicity and those that were not exhibiting neurotoxicity. But when we look into the median dose normalized to EGFR, it's much, much higher, quite double dose in this population with very high concentrations in the blood. So we need to adjust the dosing based on the assessment of renal function, definitely. The other complexity of beta-lactam neurotoxicity is the diagnosis of such complication. Because when we look into the risk factors, we have discussed in which population we should look into a neurotoxicity. But if we look at the clinical picture of beta-lactam neurotoxicity, we can see that they are not very specific in the context of ICUs. Altered mental status, reduced consciousness, confusion may be related to other factors such as residual sedation, for example, or sepsis. Myoclonus seizures are probably easier to diagnose and easier signs to suspect neurotoxicity. And there's EEG characteristics, and we'll discuss a bit further about that can help to rule out or to confirm the diagnosis. But definitely, this is a very large panel and a widely variable time of onset as well. That makes the diagnosis difficult. And another important point to keep in mind is that the lack of seizures does not rule out the diagnosis of beta-lactam neurotoxicity. If we look into the study from Boschung-Pasquier that tried to describe the different symptoms related to cefepime-induced neurotoxicity, we can see that confusion, agitation, hallucination were the main clinical signs, with reduced consciousness and coma. So again, very difficult to differentiate these symptoms related to cefepime neurotoxicity to other confounding factors in the ICUs. But probably one way to confirm the diagnosis is the improvement or the resolution quickly after discontinuing the cefepime therapy. And the median time in this cohort to improvement or recovery after treatment cessation was around 2 days. So that's probably the way to definitely confirm the diagnosis, but obviously we would like other tools to better diagnose this complication. Why is it so important? Is there's really a clinical impact of these high concentrations of beta-lactams. This study is a very interesting study. It's a prospective study conducted in 120 patients with sepsis and septic shock, and they are asked to perform beta-lactam TDM. It was 30% cefepime, 30% piperacillin, and 13% imipenem. And what the authors found, they found that in the group with high concentration of beta-lactam, the delay to extubation was increased by almost 5 days, meaning that we have patients that are in comatose, that have reduced consciousness, that we interpret as related to other confounding factors, and not diagnosing this neurotoxicity may have a huge impact on the management of our patient with delay extubation, and also in this study increased length of stay in the ICU. So the question is definitely how to improve the diagnostic. Is it the clinical score follow-up of neurological status? Is it continuous EEG? Or is there a room for therapeutic drug monitoring in this context? Because We need to keep in mind that neurotoxicity can also occur, especially for cefepime at therapeutic plasma concentrations. Regarding EEG, we have some recent data showing that we can identify an EEG pattern in this patient, at least in 2/3 of patients with cefepime-induced encephalopathy. And these patterns was mainly generalized periodic discharge and triphasic wave. And in this cohort, the median onset of neurological symptom was around 4 days, but the median time to EEG was 8 days, meaning that we diagnose this complication too far in the course of our patient. And in this cohort, the main risk factors was the duration of cefepime use. So the conclusion here is in patients where we use cefepime for prolonged therapy, need to suspect this complication early in the course of cefepime and try to implement EEG monitoring if available at your site to try to diagnose this neurotoxicity. Probably another important and interesting tool is the therapeutic drug monitoring. And we know now quite well that there's PK/PD targets to define both the efficacy, of course, of beta-lactams to try to maximize clinical and microbiological cure. Also some targets defined to limit the emergence of resistance, but something that we underestimated for quite a long is the toxicity threshold we should look into to minimize the adverse events, because beta-lactam has been considering for a long time as antibiotics with a quite large therapeutic window, and we now need to better define this therapeutic window. When we look into the real-world TDM data in ICUs, we can see that really few patients are in the therapeutic range. That's different cohort in a critically ill patient with different beta-lactams TDM, and we can see that we significantly reduced the proportion of patients with underdosing, because we encouraged to give higher dosing in our patient. But we can experience now a lot of patients with overdosing. Of course, not all overdosing will induce neurotoxicity or beta-lactam toxicity, but that's something that we need to keep in mind. Probably the main issue at the moment is that we don't have a clear threshold for all the beta-lactams we use on the daily basis. In this narrative review, we try to analyze the literature and try to define some of the threshold and the clinical signs associated with the different beta-lactams, but we still have some penicillin or some cephalosporin for which we don't have a clear toxicity threshold, and it's probably some focus of research in the next year. But what we recommend in the French Intensive Care and Pharmacology Society in patients with quite high concentration and where we suspect signs of toxicity is to stop the administration or to perform TDM to adjust drug dosing in this patient. And probably the TDM is now something that we need to perform when we use cefepime in our ICUs. I think it's not safe to use cefepime without TDM, because we know that very high concentration in this cohort defined as a 30 milligram per liter threshold, patient will experience neurotoxicity in 100% of the time. We know that the lower threshold is very, very low when you use cefepime. And the consequences of this toxicity threshold is probably that for pathogens with high MICs equal or above 4 milligram per liter for cafedim will not be appropriate, because it's very difficult to be below the toxicity threshold of 20 milligram per liter in this context of high MIC. So that's really something to take into account, the risk of toxicity, and the need sometime to switch to another option to avoid the consequences of beta-lactam neurotoxicity, delayed extubation, prolonged length of stay, as I told you. Probably something also to take into account is the mode of administration of the beta-lactam. And we move to the continuous infusion of beta-lactam based on the BLINK-3 study. But we need to assess the steady state plasma concentration and look into the incidence of neurotoxicity in this context. And the independent risk factors in this cohort of continuous infusion of high doses of cefepime was again the risk of chronic kidney disease with an odds ratio of 7. And the threshold, the toxicity threshold was a bit different in this cohort, giving a continuous infusion with a concentration of 60 milligram per milliliter, meaning that we can have different threshold based on the mode of administration of beta-lactams, and we don't know at the moment exactly if it's the high peak concentration when we give intermittent beta-lactam infusion, or when we give a high loading dose that will induce toxicity, but definitely we need to have more data available on the different mode of administration to better define these toxicity PK/PD targets. And as Jason already mentioned, we now have more sophisticated tool to try to adjust dosing in our patient to ensure efficacy, of course. And it's for this reason that most of the population PK data have been developed, but also to consider the toxicity PK/PD target as well. And I will not go into details into the population PK modeling and the precision dosing, but that's interesting to understand that this approach can integrate very different variables that can affect the beta-lactam concentrations that will be embedded into a PK/PD model to try to tailor the first starting dose. And if you perform TDM, then you can enter this data into a dosing software to better refine the dosing adjustment, and using Bayesian approach with Monte Carlo simulations, and try to identify the optimal dosing in our patient based on precision dosing approach. And there's already some data showing that using this approach of dosing software associated combined with therapeutic drug monitoring can help to optimize antimicrobial dosing and to limit the toxicity. This is a retrospective study from Germany, included 179 patients, looking at PK/PD target of piperacillin for Pseudomonas aeruginosa, and they use TDM-guided piperacillin dosing with a dedicated software. And they showed that using this software-guided empiric dosing, they can increase the proportion of patients in the therapeutic range, but they mainly decrease the risk of high concentration and the risk of toxicity. So that's very preliminary data that are quite encouraging, but definitely we need further studies focusing on this endpoint, very important endpoint. So probably to summarize, in our critically ill patient, and probably in particular those that are already brain injured, we need to have a standardized approach to monitor the clinical signs, definitely, to try to suspect earlier neurotoxicity with mental status change, meaning that we have a clinical assessment every day after initiating any beta-lactams, with a main focus on cefepime, imipenem, and probably cefazolin as well. Probably patients with renal dysfunction definitely need a daily monitoring of creatinine clearance to adjust drug dosing daily or every 48 hours. And as soon as you suspect toxicity, need to perform beta-lactam TDM if available at your site, and EEG, and probably to consider to discontinue the funding agent or switch to lower risk alternative. That means you need to have a protocol assessing the risk of neurotoxicity for each category of beta-lactams, and to sometimes consider to switch to another cephalosporin, for example, with the same antimicrobial spectrum to decrease the risk of neurotoxicity in this patient. That's true for cephalosporin. That's the same approach among carbapenem and other drugs. So to conclude, beta-lactam neurotoxicity is challenging. The imputability in neurological dysfunction in critically ill patients in general, and in particular in brain-injured patients, is difficult to prove. We need a strict clinical follow-up and an EEG monitoring that could help us better diagnose this complication and discontinue the offending drug if there's a high probability and high concentration in the blood. Definitely, renal dysfunction is the major risk factor for this complication, and we need to perform repeated TDM, but with clearly defined toxicity thresholds in the future. And there's promising strategies definitely in the future to help clinicians to better adjust drug dosing, and dosing software is probably the best tool in the future. Thank you for your attention, and I'm happy to take any question you may have.
Dear Claire, thank you so much for the excellent talk. There's a lot of questions, and after those that you will reply online, I would be grateful if you can reply by text, because there are several questions. I will start with the first one, that they are asking if we don't have TDM, what we can do.
Yeah, sure. So that's probably the main challenge, the main issue. So first of all, I would say that obviously beta-lactam TDM is more complex than other drugs to set up in different institutions, like for vancomycin TDM or aminoglycosides TDM. So first of all, try to discuss with the lab to see whether or not it's possible to get access to TDM. There's some HPLC approach, etc. So don't give up. That would be my first recommendation. But we know that in some countries, at the end of the day, it will not be possible to get access to this strategy. So that means that definitely you need to clinically suspect this complication. Need to, again, try to get access to EEG to see if you have this pattern with triphasic wave in particular. And probably also if there's a high probability, meaning you have a brain injured patient, he has renal dysfunction, and you can see some signs of reduced consciousness, or if you have myoclonus or seizures, then you need to discontinue the drug and switch to another drugs. He should recover, as I showed you, in 1 or 2 days, and then you have the diagnosis. That's the only way, I would say, to safely use beta-lactam in this high-risk population. Definitely.
Hakan, would you like to tell the next question and then to move to Reena?
Yeah, sure. No, there are many questions, but I would like to ask to Claire if there is any time limit or threshold for the development of neurotoxicity in the course of beta-lactam use.
The time where we should
Suspect. Yes.
Suspect. So what I showed you for cafepime, for example, is that it's definitely the duration of therapy. In this cohort, it was around 4 days of therapy, where we can see some neurotoxicity. And again, the EEG was performed 8 days after the start of the therapy. So probably around 4 days, because it's obviously related to antibiotic exposure. But around 4 days is probably the where we should really look into and focus to diagnose this complication.
Thank you, Claire.
I have the pleasure to present Reena Mehta, consultant pharmacist in critical care at King's College Hospital, London, honorary senior lecturer at King's College, and chair of the UK Intensive Care Society's Learning Division. Has over 15 years experience. Her expertise includes antimicrobial stewardship, medicine in ECMO, and health inequalities. Reena oversees and leads one of the UK's largest critical care pharmacy teams, delivering expert clinical support to nearly 100 intensive care beds at King's. Welcome, Reena.
Thank you, Despoina. Thank you for that kind introduction, and also thank you to ISAC committee for this kind invitation to speak today. So I'm going to be taking a different angle. So I'm going to be talking more about how you move translational research into everyday practice for beta-lactam continuous infusions. I have no disclosures for this talk. And so I'm going to briefly discuss the beta-lactam PK/PD, and I know a lot of this has been covered already. What's the evidence for prolonged, which is extended or continuous infusions versus intermittent infusions, discuss the safety profile, the challenges and key considerations for implementation, what information is out there around economic evaluation and implementation tools. So what we do know is that beta-lactams are the first-line antibiotic therapy in the ICU. And as you've heard, there's been a lot of focus on strategies to optimize the PK/PD drug targets. So what we do know is that beta-lactam antibiotics have a better bacterial killing when the free drug concentrations are maintained above the MIC. And this is referred to as time-dependent bactericidal activity. And due to this biological rationale, use of continuous infusions should lead to a greater time above the MIC and potentially better clinical outcomes for the patients. So what I'm compared to standard dosing, which is intermittent infusions over 30 minutes. So what I'm going to show is some of the data on antibiotic plasma levels using standard intermittent dosing. So this was mentioned by Jason earlier. So the DALI study. So this was a study that had 361 patients across 68 hospitals, and they looked at the contemporary dosing and reported on the free antibiotic concentrations above the MIC at 50 and 100% of the dosing intervals. And what you can see, especially on the figure on the left, is this large variation in concentration. And they reported up to a 500-fold variation in concentration, which is concerning. And they concluded that 20% of their patients did not achieve the conservative PK/PD target. And of those 20%, 32% were more likely to have negative outcomes. So at the moment, our standard dosing is showing it's unable to achieve these optimal therapeutic levels. This is another study. It's a study done in Sweden by Fredrik Joel and his team. They looked at 3 beta-lactams. So it's a single central observational study. And they looked at intermittent dosing. And they reported on the PK endpoints of achieving 100% free antibiotic concentrations above the MIC and at 4 times the MIC. And again, they showed a figure, which is on the left, to show this wide variability in beta-lactam concentrations. And they concluded that about 25% of the patients failed to achieve an optimal PK/PD target, and 40% of the patients only reached that target attainment of 4 times above the MIC. So there comes the question, so can we administer beta-lactam antibiotics in a more effective way in the ICU? We've heard that the pharmacokinetics is less predictable in critically ill patients due to factors such as volume of distribution and altered renal clearance. So over the last decade or so, there's been a body of research regarding RCTs looking at continuous versus intermittent infusions in sepsis and septic shock. So I'm going to highlight some of the key RCTs, and this is before BLING-3. So the first one, BLING-1, what it showed was use of continuous infusions led to higher plasma antibiotic concentrations and improvement in clinical cure. This was followed by BLING-2, led to improved PK/PD target attainment. After that, we had BLISS, which showed significantly higher clinical cure rates, and also the MERCY study, which showed better target attainment with continuous infusions. But they all showed a mixed mortality benefit in the individual studies. During this same period, there's been a number of systematic reviews and meta-analyses looking at continuous extended versus intermittent infusions. And many of these have shown similar outcomes. And I'm just going to highlight some of them. So this is the first one I picked up in 2016, showing continuous infusions led to lower hospital mortality. And there's been a consistent message of improved mortality benefit and clinical outcomes. So again, we're seeing the same thing repeatedly. And also during the same period, there's been a few international consensus guidelines recommending prolonged infusions. So in 2021, we had the Surviving Sepsis Campaign updated guidelines, and there is a weak recommendation for using prolonged infusions. This is then followed by the French societies, who also recommended use of prolonged infusions in 2019. And more recently, we have this international consensus that's endorsed by many prominent international societies, such as ESCMID, BSAC, SCCM, who also recommend using prolonged infusions. So then in 2024, last year, we had the publication of BLING-3, and this was the largest prospective multi-center RCT. It recruited over 7,000 patients across 104 ICUs. And what it concluded was, in its pre-specified adjusted analysis, they're shown a mortality benefit and a higher clinical cure rate, but there was no difference in the other outcomes. Now, if you add this data, you get the most recent systematic review and meta-analysis, which was actually published last summer in JAMA as well. And this basically included 18 RCTs with over 9,000 critically ill patients with sepsis or septic shock. Now, what's important to note is that 17 of these RCTs compared continuous infusion versus intermittent infusion. And they reported a 14% reduction in all-cause 90-day mortality, a higher clinical cure rate, and a lower risk of ICU mortality. But the important thing is, what does that translate to? And it translates to 26 patients needing to be treated with a prolonged infusion to save one extra life. So our results are strongly suggesting the use of continuous or extended infusions as a standard of care. But we know it's not just about efficacy. As Claire was just discussing, we also need to think about safety profile. Now, we know that beta-lactams are well tolerated, and the safety profile is not commonly reported in many trials. But just looking at the trials I discussed earlier, the RCTs, there was no difference in adverse events between the groups. If you look at the systematic reviews of continuous extended versus intermittent, again, there was no difference in reported adverse events between the groups. Interesting, this meta-analysis came out last year as well, and it was purely looking at the safety of standard versus continuous extended infusions. And it also concluded that both infusion protocols demonstrated similar adverse event rates. So given the weight of evidence, we have an intervention with a high certainty of significant patient benefit and a low risk of harm. So the question is, how do we move these research findings into practice? So there are a number of challenges and key considerations, and I'm going to briefly discuss them, but I'm going to concentrate mainly on piperacillin tazobactam and meropenem, as they are the most widely used. So translating research findings into clinical practice can be slow, and this is due to system and staff associated barriers. So it's important to establish a core team prior to implementation, and this should include microbiologists, pharmacists, intensivists, as well as nurses. And it's important to understand from each of them what their attitude, challenges, or barriers are. So example, in resource-limited settings, you may have a high patient-to-staff ratio or lack of availability of any of these key disciplines, and that may affect uptake. Communication and engagement needs to be done to the wider stakeholder team. So this is to all staff in areas that may come into contact with these continuous infusions. And also, as this is an off-label route of administration, the correct governance process needs to be followed. So in terms of location, where you will use this, you need to establish your workflow. So will it be used in the emergency department? Will it be used on the wards at all, or just in ICU, or in a combination of them? But what we do know is that in some countries where ICU beds are insufficient, they will need to consider safe implementation, possibly on the wards, to avoid delays of starting antibiotics. So patient selection, again, will you be using it in all patients or just in those with sepsis or septic shock? And as has already been highlighted, is it important to achieve that PD target? And actually, is it feasible? And it's also challenging to do an RCT in every subgroup of infection. Therefore, be pragmatic, especially in the absence of TDM. I can't emphasize enough the importance of education and training. So ensuring all staff have a good understanding of the change and invest in pharmacy and nurse training as well as doctors. And finally, measures of success. Once you go live, you need to think, how are you going to measure it's working? And this may be looking at process measures, such as compliance to guidelines, is a loading dose given, or clinical outcome measures, such as antimicrobial resistance rates. And these will be relevant to each unit, but you'd have to ensure you've got easy endpoints to measure. So you need a systematic approach with a good infrastructure. Now, loading doses. It is vital to give a loading dose. And this lovely Monte Carlo simulation simulated piperacillin concentrations in the first 12 hours of therapy with and without a loading dose. And what you can see is by giving a loading dose, you were able to reach the Pseudomonas breakpoint in 3 minutes, versus without a loading dose, it took 1 hour, 54 minutes. So the rationale, giving a loading dose rapidly achieves that plasma target concentration above the MIC. It also compensates for the increased volume of distribution and augmented renal clearance, which is typically seen in this patient cohort. Now, the dose is independent of the presence of organ failure. So what that means is if you've got a patient with renal dysfunction, you don't need to change or reduce the dosing. Always, after you've given the loading dose, follow that with the maintenance infusion, as you don't want to reduce the pharmacological benefit of the loading dose. And currently, there isn't a consensus on what the optimal loading dose is, or the duration of administering it, or when to reload, but it's reasonable to give the same as an intermittent dose. Now, this is a subgroup of a meta-analysis that showed that use of a loading dose led to significantly lower mortality. And this is also another subgroup meta-analysis that showed loading doses led to significantly increased clinical cure rate. Loading doses are also recommended in the surviving sepsis guidelines. So talking about infusion pumps and intravenous access, what do you need to consider? So very important is to ensure you have enough infusion pumps. Now, infusion pumps will vary on capability and technologies available. So for example, in well-resourced settings, you may have smart pumps with drug error reduction software, compared to maybe in resource-limited settings, you may have gravity-driven systems. In those cases, you have to be mindful of the fluctuations in antibiotic plasma levels. Ideally, you want to administer this through a dedicated line, and this can be a central line, a PICC line, or even a peripheral line or a midline. But if you are going to put an additional line, you need to balance the additional lumens versus the increased risk of thrombosis, infection, or occlusion, especially from multiple invasive devices. One thing to do is think about how long is the duration of therapy, and actually, if a line isn't available, can you co-infuse it with another compatible drug? And using your pharmacist, if available, as a resource to be able to check the diluents, the rate, the concentration for compatibility. Where possible, try to avoid giving it with infusions that require repeated boluses. So it is essential infusion lines are flush when the infusion is stopped or finished. And this will actually be more significant for smaller infusion volumes or long IV lines. And one of the key things is to avoid interruptions. So the important thing is to educate relevant staff, especially if a patient goes out of an area to another area, like scans or to theatre, to not stop the infusion. But we know that disconnection may need to happen. If it's a non-urgent drug that needs to be administered, ideally finish the bag or the syringe that's being used. If it is urgent, flush the line between the drugs, because it's important to ensure that the full daily dose is given in the 24-hour window. So important aspect that comes up a lot is stability. Now, as this is an off-label method of administration, it's uncommon to find a lot of stability data from the drug company. But there are a number of resources that have now been published that are extremely helpful. So this is a systematic review that provides stability data for extended infusions in the inpatient setting, and this was published last year. In addition, Claire Roger and her team, there's been this practice guideline that's come out from a French consensus of experts, and it includes beta-lactams and other antibiotics, and it focuses on drug stability, preparation, and practical implementation. So thinking about piperacillin, tazobactam, and meropenem, based on various RCT stability data, this summary table was published in Intensive Care Medicine last December. And this talks about piperacillin tazobactam, and it is considered to be quite stable when diluted in 0.9% saline, sodium chloride, or 5% glucose for 24 hours at 25 degrees. This is a practical benefit because you can give one bag changeover into a 24-hour period. But on the other hand, meropenem is slightly different. It has a shorter duration of stability as it's more sensitive to changes in temperature, diluent, and concentration, and therefore you need to give multiple back-to-back infusions. Its stability is also reduced in glucose solutions. So always ensure your infusion is prepared as close to the time of administration. So Jason discussed renal replacement therapy, and this publication came out this year, which is a prospective multinational pharmacokinetic study where they looked at patients requiring various forms of RRT, and they used population PK models and Monte Carlo dosing simulations. And what they concluded was that use of extended and continuous infusions led to better achievement of optimal antibiotic concentrations. And actually, continuous infusions themselves appeared particularly advantageous when the higher MIC concentrations were required. So what we do know around renal replacement therapy is that piperacillin and tazobactam and meropenem clearance is reliably predicted by the effluent flow rate. Therefore, if you have a higher flow rate, you're going to get increased clearance, and therefore higher doses may be needed. But we are mindful there will be areas in which intermittent modes of hemodialysis will be used, especially in low resource settings. And this does add complexity to dosing, especially in the absence of TDM. But do consider using extended infusions if continuous infusions are entirely not practical, and always remember to dose post-dialysis. Some places will have prescribing tools. If they're available, please use them to help you support dosing decisions. So thinking about guidelines, as Jason mentioned, this is the baseline and the minimum standard, but it will help with standardizing practice, and you will need to adapt these to different settings. So ideally, if you have a national guideline, it will probably support implementation further. But these are just a few things to think about to include in your guideline. So location of the intervention and the patient selection, as discussed earlier. The dosing. So this is the loading dose, the reloading dose, as well as your maintenance dose. Now, where you are using an electronic prescribing system, you could also put standard orders or order sets to support administration details for the nurses to avoid delays, compatibility with common IV infusions, again, to prevent delays. An important thing is about managing interruptions in therapy. So when an infusion is stopped, the plasma concentration will start to decrease rapidly. And therefore, when it's restarted, you need to think, do you need to give an additional loading dose? And how do you give the remaining dose to ensure the full 24-hour dose is given? And the important thing is to be pragmatic. You might want to include dosing in renal impairment, on renal replacement therapy, or in augmented renal clearance. So as we know, beta-lactams are reliably cleared on renal replacement therapy. Please don't underdose. It's really important that at least the first 48 hours you give a full dose. And lastly, just as important is discharge planning. So if a patient is going to be discharged to an area where they're not using continuous infusions, you need to consider what dose to change the prescription to, when's the next dose due, and clear communication is required on discharge. Overall, you need to keep it simple and keep it accessible. And these are just a couple of resources that are useful and that set out the principles to consider for implementation. And this is another resource that includes the stability tables. So moving on to environmental sustainability. So reducing the ecological footprint in an ICU is the responsibility of all of us. So whereas there isn't data on CO2 emissions, a group in Rotterdam reported on this, and they looked at the sum of waste related to the preparation of continuous versus intermittent infusions over 24 hours. And what they concluded was continuous infusions of piperacillin tazobactam resulted in less waste than intermittent infusions. And that's most likely because you're only giving one bag, and no difference was seen with meropenem. but also using syringes instead of infusion bags resulted in considerably more waste. Now, you will have countries where renewable energy sources are not being used, and therefore additional electricity consumption for infusion pumps also need to be considered. So economic evaluation. So we're getting asked about what information has come out around this, but it's not extensively investigated. It is mainly single center observational studies with variations in dose comparison. And if I take you to the column on the right, which is outcomes, what you can see is that using continuous infusions, people have reported for it to be least time consuming and costly, lower labor supply costs, significantly lower level 1 and 2 costs. So there is a signal towards a cost-effective intervention. And we're hoping that there may be some data from BLING3 that will support what we do next. So lastly, moving on to the how. And I'm sure many of you are looking at this slide thinking, what is implementation science? So this is not on whether an intervention works, but how to ensure it is adopted, integrated, and sustained in everyday practice. So it's basically strategies to move research findings into the real world setting. And I'm just going to quickly mention 2 frameworks. So the first one is the CIFR, Consolidated Framework for Implementation Research. It has 5 domains, and I've put QR codes and links to be able to read more into it. And it helps you to identify barriers and facilitators to change and helps you develop targeted strategies. And the other framework is REAIM, which is one that also has 5 domains. And the idea is to help you think about your planning, your implementation, evaluation, and sustained adoption. So the goal of using these frameworks is to ensure that implementation is impactful and feasible in the real world setting. So in summary, prolonged infusions are considered gold standard, and we can see there's a strong clinical evidence for the use of continuous infusions. Like I said, 26 patients are needed to treat with a prolonged infusion to save 1 extra life. They have a good safety profile. They provide greener clinical practice when used with an infusion bag. And practical considerations, as discussed, are very important for sustained adoption, and you will need to adapt this to local services. Global implementation requires adapting to an infrastructure, staffing, and economic constraints. So the idea is to remove the barriers, as this can lead to major improvements in treating infections. And finally, implementation science frameworks are a good starting point. But we know that continuous infusions is not a one-size-fits-all. If you cannot do continuous infusions, please do consider doing extended infusions. Thank you.
Thank you, Reena. It was very concise overview of extended infusion. I'm checking the questions now. Now we have many questions, but if I may, I would like to start with my question. I'm living in Turkey, and in my hospital, the most common gram-negatives are Acinetobacter species and Klebsiella isolate. 98% of Acinetobacter species are carbapenem resistant, and carbapenem resistant in Klebsiella isolate is more than 80%. So time to time at the bedside, when we are recommending antimicrobial treatment in the ICUs, I have some concern that because of the resistant issue, continuous infusion may fall below the MIC range of the antibiotic we are giving. So do you think that we should prioritize these resistance levels before recommending continuous infusion?
So I think what the difficult thing is, getting data back on resistance levels isn't always in real time, and it's always a delay in doing that. So one of the important things is the emphasis of giving a loading dose and ensuring you're getting those drug concentrations well above the MIC to ensure you try and reduce resistance in the long term.
I would like to thank the attendees and the faculty, and I would like to invite you to the following parts of the webinar series, the second and the third one. So 11th of December, same time, we have the session 2 of the webinar series of ISAC jointly with ESGCIP and King's Critical Care with Matteo Bassetti, Demosthenes Makris, Jean-François Tirsid, and Antoine Roquilly. and 20th of January, the third part, that is with Stefan Hagel, Phil Hopkins, Yazaveri gonna listen the perspective of tropical countries, and Emine Alp from Turkey. Thank you, all of you. Thank again the faculty. Thank you, Fee, for arranging everything.